great pleasure to welcome all of you all for the 53rd ESI Foundation Day. And before I hand over the proceedings to my co-host Nitin, who, to be very honest, has actually done all the hard work behind this meeting, I want to ask Nitin a very pertinent question. Nitin, why exactly have we gathered today, and what is the significance of the Foundation Day before we actually start the proceedings?
Thank you, Dr. Shaila, and I think it's a great day. So in very simple words, if I have to say, today is the 53rd birthday of our very own society, the Endocrine Society of India, which was established way back on 10th of January, 1971. So we are actually celebrating our 53rd birthday, 53 glorious years where our society has grown leaps and bounds. And we're going to look at that shortly after the CME, where we have a very exciting video coming up showing all the activities that we do, and it's really, really amazing. But let's contain our excitement till then. And this is also January, which is the Thyroid Awareness Month, and that's why the theme for today's CME is the recent advances in the field of thyroidology within India. And before we move any further, I would like to invite our President of Endocrine Society of India, Dr. P.K. Jabbar sir. Obviously, he needs no introduction in the endocrine family. Sir is Professor and Head at Government Medical College, Trivandrum of Endocrinology Department. And sir is also the Director of the famous Indian Institute of Diabetes in Trivandrum. I request you, sir, to please give the welcome address and also invite our senior teacher, Professor M.S. Sheshadri sir, to the meeting.
Good evening, sir. Warm regards from God's own country, Kerala State. Respected senior teacher, Sheshadri sir. My vibrant secretary, Dr. Hari Kumar, Dr. Nitin, Dr. Shaila, Sujoy, Saptarshi Sambit, Dr. Mohan. I'm very happy to face this August audience today because we are celebrating the 53rd birthday of our ESI. Sheshadri sir knows the history of Endocrine Society of India. It was formed the same day, Jan 10th, 1971 at Karnataka State. Subsequently, our age is 53 now, with a very strong backup, academic backup, research backup, and see the membership, the strength is also very, very good. I'm extremely happy to say that, and I'm proud to say that I'm the president of most vibrant academic forum, that's Endocrine Society of India, for this year. I'm more or less, if you ask me, which is the most memorable event for me, that is for today, because all my teams are waiting. All my friends are waiting to listen to me, and they are going to give a lot of academic inputs for our members. For that, we have chosen one of the very, very eminent personality in the field of endocrinology, Dr. Sheshadri. Sheshadri sir is a very, very senior person, probably teacher for teachers. And regarding our society is very actively involved in academics, research, and of course, say the education for public as well as practicing physicians. My predecessors, my friends, they were very active as president of our society, and they did maximum possible for our society in terms of social reach, academic reach, research wing, everything they were doing very efficiently. If you remember our programs, we have a number of programs which is addressing all status of doctors. We have programs for youth, we have programs for women, we have programs for other group of doctors, and very actively involved in social media to reach the interior part of India so that we can have our own identity. Especially we have our strength. You know, we started with probably 7 or 10 members for endocrine society. society. In addition to that, every year you are going to days are coming to the Forum of Endocrine Society. So we have to be very active. Unity is a strength. If you remember the Panchatantra stories of our society, for which our group or committee, executive committee members are doing very good work to enrich in all aspects. There is no doubt about that. So my duty is to welcome all my friends, including our chief guest, Dr. Seshadri, and my friend or speakers, Dr. Sujoy, Dr. Krishna Seshadri from Madras, Dr. A.G. Unnikrishnan, and we have moderator Dr. Arun from Kochi city, and of course, my friends Dr. Shaila and Nitin as hosts for today. I want to welcome all my friends with one word, a special welcome for our Foundation Day for Endocrine Society of India for today. In addition, let me introduce my teacher or our teacher, Dr. Seshadri. I think it is little superfluous to introduce Dr. Seshadri to this crowd because he's a well-known figure. He did MBBS from Coimbatore and subsequently graduated from CMC Vellore also. He's a recipient of lot of awards also, very active academically and very active in all the conferences also. Good orator, good clinician, and is taking a lot of interest in teaching basic endocrinology. Of course, that's a clinical medicine. I feel since I mark even this high-tech era of endocrinology. With these humble words, may I invite Seshadri sir to start his the felicitation and his remarks and his talk also. Over to Seshadri sir. Thank you very much once again, and warm welcome to all my friends, delegates, and the respected speakers. Over. Thank you very much. I'm signing off for the time being.
Thank you very much, Professor Jabbar, President of the Endocrine Society, and my dear friends, young and old, who constitute part of the audience. It is indeed a very fitting tribute to the Foundation Day or the birthday of the Endocrine Society to have an academic feast by young endocrinologists who have actually done original work in the field of thyroid disease. Thyroid disease is second only to diabetes in terms of frequency in endocrine disorders, and our country has the entire spectrum of thyroid disorders and different types of problems in different parts of the country. Iodine deficiency and disorders in the northern states, and more of autoimmune thyroid disease, southern states, and thyroid malignancy, of course, all over. And it's indeed fitting that we are going to have talks on newer methods of evaluating thyroid cancer. And we are going to have a talk on how to go about using ultrasound as a tool in diagnosing thyroid disease and the extended spectrum of disease associated with thyroid autoimmunity, just beyond thyroid disease. So we are going to have very erudite speakers today who are going to talk about this. And it is indeed an eye-opener for me in many ways over the years, the way the Endocrine Society has progressed. I recall the earlier meetings, which used to be part of API, and I'm sure Professor Jabbar also will remember that, until we separated out into a separate Endocrine Society meeting. The content has progressively become better and better. And work coming in from India, which is widely acknowledged all over the world now, is taking center stage in our Endocrine Society proceeding. with these few words. I feel very happy and I feel very honored that I have been asked to chair this session by our young colleagues in thyroidology. Thank you very much for having me over here.
Thank you so much, sir, for that felicitation and addressing the gathering. I now invite Sheshadri sir to chair the session and invite our first speaker for the day, Dr. Sujoy Ghosh.
Anybody who had attended the Endocrine Society meeting in Hyderabad will remember this very dynamic youngster who presented his original work on cell-free DNA and liquid histology in the diagnosis of thyroid cancer. Very, very well done work, which was published in, I think, the Journal of Clinical Endocrinology and Metabolism. And Dr. Sujay has the unique distinction of editing the endocrine section in Davidson's textbook of internal medicine, which was, in my days, the Bible for undergraduates. The unique distinction. The National Joint Secretary of the Indian Thyroid Society, National Vice President of the RSSDI. I worked as a clinical faculty overseas in the University of Glasgow and has had several international awards, including the AAC Award as for an International Clinician of the Year 2021. And he has published over 500 articles and has contributed several chapters, books, and he is a co-author of books. It's our unique privilege to have Dr. Sujoy talking to us about his work on thyroid cancer. Dr. Sujoy.
Good evening, and thank you very much, sir, for that very kind introduction. A big thank you to the Endocrine Society of India for having given me this wonderful opportunity to speak. And because of some technical glitches, I've requested Dr. Nitin to share my slides. Dr. Nitin, if you could make it full screen, please.
Okay, sorry.
And sir was talking about that I had presented this work. You can share the slides. I wanted the slides to be
yeah.
So I have shared some of my work in the PN Shah oration of ESICON 2023 that was recently concluded in Hyderabad. And I was again asked to talk about it. And of course, at a much shorter duration of talk. So it's going to be a big challenge to at all talk about everything that I've done. Even in the oration, I spoke probably about 40% of the work that we've done. There is 4 more publications that are waiting to come out of this work that's still ongoing. If I can have the first slide, please. Next slide. So we are all aware as endocrinologists that thyroid cancer is the commonest malignancy that we deal with. And in about 3/4 of patients with thyroid cancers, there is now a known driver mutation. So for example, we are talking about the BRAF 600 VE, or whether it's some of the RAS mutations or say TERT or RET PTC. So these are mutations that develop over a period of time, which ultimately lead to a neoplasm, which can be benign or malignant. So you have to have some degree of genetic susceptibility, which will drive the causation of a thyroid nodule, benign or malignant. Next slide, please. So as part of the investigation, we usually ask for a normal thyroid function test in someone presenting with a thyroid nodule, followed by an ultrasound. And where indicated, we stick in a needle and we do an FNA and report it according to the Bethesda system of reporting. Now, in that, we have problems in 3 sectors. Number 1, if it's Bethesda 1, which means you've got to repeat the FNA. And more importantly, it's categories 3 and 4. So these are individuals who we term clinically as indeterminate nodules. Now, in the Western world, where they have facilities for molecular testing on the FNA sample, they usually do those tests. Whereas in India, because we don't have widely available facilities for genetic testing, we try to re-establish what could be the chances of malignancies. Maybe in some cases, we wait and watch and re-evaluate, and the others we send for surgery. Now, the ones that we send for surgeries, 3/4, that means 75% of them will come back as benign. So technically speaking, those individuals did not need a surgery. And in the ones where it comes back as malignant, despite of what we want, the surgeon usually performs a hemithyroidectomy. You have a diagnosis of a malignancy, and we then ask the patient to go back to the surgeon for a completion thyroidectomy. So you are subjecting the individual to 2 surgeries. So that's the problem. Next slide, please. So the indeterminate nodules have a problem because of the reasons that I've told you. And the other issue is, even if you have an FNA diagnosis of malignancy or a benign tumor, after the surgery, you have no way of following up those individuals because your essential starting material was FNA and not blood samples. So you don't know whether the disease, there is residual malignancy, and you cannot tell us whether there is any recurrence of malignancy because you need a histopathological tissue or a cytological tissue for that diagnosis. So keeping all of this, we think liquid biopsy would be useful in our patients. Next slide, please. So the molecular testing that are available worldwide are essentially on the basis, they work on 2 principles. Number 1, either they detect a driver mutation or they look at permutation and combinations of certain microRNAs which are thought to be related to malignancy. Next slide. The challenge and the problem of these are that these are either rule out tests or these are either rule in tests. And therefore, at an individual patient level, it is often difficult to make a clinical decision whether this is benign or malignancy, particularly because RAS mutations can be present both in benign lesions as well as malignant lesions. Next slide. And therefore, we know, for example, in category 1, you can't go on repeating FNAs all the time. The molecular tests available internationally are expensive. They have unacceptably high negative predictive value. They are not available in India, and you cannot detect residual tumor or disease recurrence. Next slide. So therefore, we come up with this concept of liquid biopsy. So can we move on to the next slide, please? Can you click again? Click again, right. So here, this is actually a figure that I've taken from New England Journal of Medicine, which was published a couple of years ago. So if you take a sample of a fluid from somewhere else rather than the actual tissue that you're concerned about, and if you're able to predict malignancy, that entire concept is called liquid biopsy. In our case, we are taking peripheral blood samples. So even if you're taking peripheral blood samples, you might, in some malignancies, have circulating tumor cells. That has been used in breast cancer. It can be exosomes, which has been used in colonic malignancy. It can be cell-free DNA like I have used. And in the cell-free DNA, you can look at the driver mutations that I was talking about, which we will discuss. In clinical practice, you already have driver mutation in the cell-free DNA in clinical practice. In lung cancers, you are looking at EGFR mutations, which is now already being used in clinical practice. The next slide. So what you can look at in that cell-free DNA is obviously the driver mutation. You can look at copy number alterations. You can look at certain gene fusions and DNA methylations. In our study, as of now, the 2 papers that we've published, one in JCM and the other in the European Society of Endocrinology Journal, EJE, European Journal of Endocrinology, we've looked at the concentration of cell-free DNA and the presence of driver mutation in the cell-free DNA to tell us first whether there is malignancy, and if so, what is the driver mutation that drives that malignancy. So for example, even if your FNA told you you've got PAPCA thyroid, is it a BRAF-mediated PAPCA or is it a TERT-mediated PAPCA? Because the outcomes of the 2 are very different, which you can predict, and you can be more aggressive in one and maybe not that aggressive in the other. The next slide, please. So overall, if you look at cell-free DNA, it can be used in screening, detection, and diagnosis. I will show you that you can even use it in cancer staging, initial therapy stratification. You can detect residual tumor. You can even monitor treatment and detect relapses. Next slide. So coming to our study, the next slide. This was published in the JCEM 2 years ago. Next slide. So what we essentially tried to do is, because our clinical problem is mostly limited to the intermediate category of indeterminate thyroid nodules, so we wanted to see whether the levels of cell-free DNA concentration in such nodules help us to differentiate benign from malignant nodules. An oversimplistic explanation of why cell-free DNA concentrations might increase is because we know when you have a malignancy or a tumor, there is likelihood of greater levels of apoptosis and cell necrosis, which would lead to the release of the DNA from the malignant cells into the circulation. And therefore, this would be in circulation for some time before it gets removed. Now, remember, there are several caveats to this. Number one, if you have an inflammatory situation, burns, infection, where there is tissue damage, the same thing can happen. But we've used a simplistic test in terms of raised cell-free DNA. So I'm not going into the details of the methodology of how we isolated it. To cut a long story short, most of us have a biospectrophotometer in our labs in the hospitals that we work, and you can buy a DNA isolation kit commercially available. The test would cost you 40 rupees per test. The next slide. So what we did was we recruited, now this number has actually gone up. We recruited almost up to 320 odd patients. Because of the purpose of the study, we only included those who had solitary nodules, because when you're looking at histopathology or FNA, if you have multiple nodules, it's difficult to figure out which is what. We excluded TIRADS 1, Bethesda 1, and hyperthyroid individuals because we don't know what happens in Graves. And we did a basic thyroid function test, we did an ultrasound, and we subjected our patients to an FNA and categorized them into benign, that is 2, 5 and 6 where we thought there was malignancy, and the indeterminate nodule. Now, all of the 5 and 6 underwent surgery. So you have a histopathological diagnosis whether they're actually malignant or benign. And the benign ones, a proportion of them underwent surgery and were diagnosed as benign, and the rest we presumed them benign because we followed them up and thought that they were benign. The indeterminate ones also were subjected to surgery for having a histopathological diagnosis. So whatever we are comparing with the gold standard of histopathology. The next slide. This is probably the most important bit of this study if you're looking at. On the left-hand side is the first phase of analysis, where you have one group which is benign and the other group is malignant. You knew this even before you did the surgery. You just did the surgery to confirm the histopathology. And we looked at the cell-free DNA concentration in the two groups, and we did an ROC curve and found out a cutoff value above which you think that these individuals have malignancy. Now, you might say you've come up with a cutoff of say 69. So if it is 68, is it benign? Just to let you know that this is a test which does not have any noise in between. All our benigns were less than 20 and all our malignant ones were above 70 or 80. So in between, there was hardly any values telling us, the chances of, because, mathematically what you're looking at an ROC is a mathematical value. But from a clinician's point of view, it's very important to know, is there anything in between? So not surprisingly, if you look at the ROC curve, it's a very atypical ROC curve compared to what you see in most of our clinical studies. So with this cutoff, we went back to our samples of the indeterminate thyroid nodules and utilized that cutoff to say, can we predict individuals who are benign versus malignant? And we did pretty well with more than 90% sensitivity and specificity of diagnosis of malignancy. The next slide, please. So a lot of you might wonder and say, who has told you that this cell-free DNA increase is because of the thyroid nodule per se? So after the surgery in the patients who had cancer, we showed that the cell-free DNA levels normalized 2 weeks after the surgery. So essentially telling us that the source of that increased cell-free DNA was the thyroid nodule per se. The next slide. Now, this is exploratory data. We tried to stratify even the raised cell-free DNA in patients with malignancy to see, can there be a prediction with the TNM or the other staging classifications of thyroid cancers? So I've told you all of them had levels above 70. Now, for example, if it was above 84, it was stage 2. If it was above 98, it was stage 3. So we found that this is pretty logical in the sense the higher the tumor load, the greater is going to be the cell-free DNA. So this, take it with a pinch of salt because this was not a pre-specified endpoint. And therefore, in a larger cohort, we'll actually have to validate this finding. The next slide. Now we've told that the cell-free DNA level is increased. Now we need to figure out within that cell-free DNA, do we have the driver mutation specific for thyroid cancer? Then we will be able to say with certainty that that increase of cell-free DNA has definitely come from thyroid malignancy. And those mutations will be able to tell us what kind of cancers we are dealing with. The next slide. So again, to cut a long story short, even for the first study that I showed you, the publication, and even for this, in both the studies, we had the blood samples, that's the plasma samples, we had the FNA samples, and we had the histopathology samples. So everything that I've told you in terms of the diagnosis is validated in all three samples, so that you know exactly that it is where it is coming from. So similarly here, we tried to look at a panel of 8 gene mutations. Now we know that there are many more driver mutations than 8 genes. But in Nikiforov's publication in JCM about 8 years ago, when they first came up with the commercial kit, they showed that I said 75% of the patients have a known driver mutation. Of them, 98% of them have these 8 driver mutations. So that's the reason why we chose this panel of known driver mutations. The next slide. So what we did was we looked at the people who had a mutation. Now this, it might be looking confusing because you have a group of people who are malignant who don't have mutations. And the other side, you look at the blue, people have mutations yet they are benign. How to interpret that? So we know that the malignancies will all, at least 75% of them will have a known driver mutations. So those mutations is in the first column on the left-hand side. You can see mutation positive 75. And not surprisingly, about 1/4 of them, of the malignancies, don't have a known driver mutations. All of them turned out to be papillary thyroid carcinoma, because that is what literature tells us, that not everyone will have a known driver mutation. On the other side, if you look at, several of the benign tumors have a known driver mutations, and they are all RAS mutations, and these are follicular adenomas. So if we move on to the next slide, what we will show you is we've used the data from the 2 studies to stratify the results in 2 ways. Number 1, you look at the cell-free DNA. If it is increased, look at the positive mutations. If they are there, then these are definitely malignancies with the kind of mutations. The subtypes will be determined by the mutation that you have found there. And not surprisingly, 1/4 of them will have high cell-free DNA, but no detectable mutations. Therefore, they will turn out to be papsia thyroid. That's exactly what's happened. On the other hand, if your cell-free DNA is low and you have a known RAS mutation, you're dealing with a follicular adenoma. And if you have no mutations, and if you don't have raised cell-free DNA, you're dealing with a whole bunch of other benign disorders. The next slide. So, if you look at just the mutations only, you can see you still have a very good sensitivity specificity, similar to the commercially available kits that people are using on FNA samples. The positive here is you're not needing FNA samples. You're doing it on a blood sample, which obviously has the advantage of detecting residual tumors and which has the advantage of detecting recurrences. So we did it with an ARMS PCR, and then we validated our results with a Sanger sequencing followed by a next-gen sequencing. The next slide. This is in the plasma. The next slide shows the same results in FNA as well as tissue samples. The next slide. So this we published in the European Journal of Endocrinology. The next slide. So what's the translational significance of the present study? If you can move on to the next slide, please. So if I know someone has got high cell-free DNA and a known driver mutation for cancer, I will advise my patient to go for total thyroidectomy. If the cell-free DNA is high but mutation negative, I will still go for a surgery. If the cell-free DNA is low and mutation is negative, I will follow up the patient. If the cell-free DNA is low and is RAS positive, I am dealing with follicular adenoma. So that's where the case lies. But there is still certain nuances. I'm sorry, I cannot talk about the microRNA data that we have, the long non-coding RNA data that we have, and the exosome data that we have already done. The next slide. These are my references. Next, please. And I would like to thank my funding agencies, without whose help, obviously, we can't do studies like this. The Endocrine Society of India, the Endocrine Society of Bengal, the Indian Thyroid Society, the Department of Science and Technologies, the senior professors in the department, and a whole lot of people, including my PhD student, Shushmita, who's done most of the work. Thank you very much.
Sir, you're on mute, sir. Sheshadis.
Can you hear me now? Okay. Thank you
Yes,
very
sir.
much for a very simplified presentation of the rather complex work that you have done over time, and for giving us a simple method of approaching the difficult problem of the indeterminate report on FNAC. I think that is where the crux of the matter lies. The indeterminate nodule, where you want to decide which ones to put up for surgery and which ones need a close follow-up and which ones need the usual follow-up. I think that is where your work is likely to give us much more clarity in terms of management. I think the questions will come at the end of the session.
Yes, sir.
And I think we'll go on to the next talk by Professor Krishna Seshadri, who I'm sure doesn't need any introduction because he's there in every endocrine society meeting as one of the speakers who comes up with very, very clear ideas. I think anybody who listens to him talk about how to tackle obesity with, restricted eating will remember the clarity with which the subject matter was presented. So he actually has worn many hats, consultant, Chennai Diabetes and Endocrine Clinic, research lead in Apollo Sugar Clinics, professor of endocrinology and medical education, and board member of Balaji Vidyapith, adjunct professor in the Manipal Academy of Higher Education, and a recipient of several awards and orations from the Endocrine Society and other bodies in the country. Former honorary secretary Endocrine Society of India, where he actually was a very, very dynamic secretary. And with his dynamism, he also initiated the Endocrine Society of Tamil Nadu and have been conducting trendos in every successive year very successfully. Editor-in-Chief of Thyroid Research and Practice and International Journal of Clinical Metabolism and Diabetes. So we are in for a feast now. His topic is actually on ultrasound of the thyroid. He is going to tell us how to very simply approach this topic, okay, to simplify thyroid ultrasound for the practicing endocrinologist. Dr. Krishna Seshadri.
Thank you. Can I share my screen?
Yes, sir.
So it's quite possible that I misunderstood my presentation, but I thought that the audience is going to be endocrinologists who already are a little familiar with thyroid ultrasound. So instead of my usual talk on, 1 second. Nitin, can you hear me?
I can hear you.
Yeah, now we can hear you. Yeah.
Okay, sorry. I think I did press something that caused a thing to escape. So for some reason, I heard Nitin send me a thing saying tips and heuristics. Is that right?
Right.
Yes, sir.
So what I did was I sort of explored this space, and I worked in. Just to let you know that my interest in ultrasound nodules has been for a long time. In fact, like Sujoy, my oration much earlier, 2009, the P. Shah oration, in fact, was on thyroid nodules. And I've been pursuing this beast for a long period of time. But today I thought I'll give a very practical talk for clinical endocrinologists. And I've sort of relabeled this talk as point of care thyroid ultrasound in the clinic, plunge or wait, because there are much more than, having a good intention to use a thyroid ultrasound in the clinic. Now, those of you remember who were trained before 2000 like me, when we first saw a thyroid nodule, we did an FNAC right there. We did not do any ultrasound. In fact, when I was a fellow, we used to poo-poo the idea of doing an ultrasound first. But here is a marquee article by Marquez in 2000 that showed that if you did an ultrasound of the thyroid, you change the management in over 44% of patients following a physical exam. Since then, things have changed, right? And this is a survey of Indian endocrinologists that Dr. Swarita Bajaj and I did a year ago, which I've still not gotten around to publishing. But remember that a third of us work in academic medical centers, and the majority of us own a private endocrine clinic, and that describes the majority of people in our practice. And of the 320 people who responded to the survey, compared to when I did the previous survey in 2009 before my oration, where 95% of people use ultrasound as the first test if the nodule and the normal TSH. But interestingly, only 8% perform the ultrasound themselves, and with good reason, as I will talk about through my talk, and hopefully, it answers several of the questions. About 88% of them also use a scoring system, and the majority of them use the ACR thyroid score. So I'm not going to talk about the ATRS, the ACR thyroids. Most of us are comfortable with the ACR thyroid score. And the reason is, one, familiarity. More importantly, that the radiologist was using it, and it suited the practice based on evidence. So clearly, from the first time I started looking at nodules, ultrasound has become centered to the management of thyroid nodules. It has eliminated FNACs to a large extent, as I will show you why. If you were to see a figure in 2001 and 2002, when I first started working with thyroid ultrasounds, and this picture is even 2010, you can see the difference in the clarity of ultrasound. Most of it is probe related, but much of it is just a post processing. You can see the clarity you see in the figure B. This is called segmentation. That actually renders the thyroid ultrasound much more easy to see. And you know why FNAC has been eliminated to a large extent is because we know what to FNAC now. For example, this is how margins are delineated. In the past, you will never be able to see this kind of a capsular invasion clearly, but you can see the capsular breach here, right? This is a hypoechoic nodule that is right in the middle of the thyroid. In the olden days, you would have missed this. And this is again looking at a small hypoechoic nodule that is compared to the strap muscles. And you can see, that the times of me and my namesake, Dr. M.S. Seshadri, whose name I have prospered a lot, this would not have been picked up. In the olden days, all of us know about the comet tail artifact, but you would never be able to say whether it's a comet tail artifact or a micronodule. But here, can you see that the comet tail artifact is very clear? This is just because the ultrasound is tremendously improved from the time that was first used for thyroid ultrasound. Here's an example of this is an older nodule, and can you see with the newer ultrasound, the micronodule is picked up. This was a Samama body. So now we have good scoring systems. These have been, remember that we use composition, echogenicity, margin, and echogenic foci. The presence of that is whether it is taller than wider, just like how breast cancers move. Whether these margins are irregular, whether microcalcifications are present, and whether they're hypoechoic can give you an idea whether something is malignant or not to a large degree. And along with the Bethesda 2, they are very well correlated. This has been our work. We have published this for many years, but that is not going to be the story of my talk. At the end of it, you have whether it's non-diagnostic, whether it is not suspicious, mildly suspicious, or others. Today, we are so confident that if you see a ACR thyroids 2, we recommend no FNAC, and if it's less than 1.5, we don't recommend FNAC for a TIRADS 3. The important thing is that there's also a recommendation that if the ACR TIRADS 2, you don't really need to follow up, while many of us follow up these patients. Just to say why ACR TIRADS is very popular, it has a very high negative predictive value. Importantly, fairly reasonable positive predictive value when compared to the ATA, almost 20% higher in terms of accuracy. But importantly, it removes the unnecessary FNAC race. So our colleagues who are using the ACR TIRADS for their ultrasound are very, very correct. This is my current algorithm. I need to start sending samples to Sujoy. So other than that, if it meets the criteria for FNAC and ultrasound guided FNAC, if it's Bethesda 2, I follow up. If it's 4, I still recommend surgery, but because Thyroseq is not available. 5 and 6, certainly surgery. In 3, I actually get a second opinion, I reaspirate, but more importantly, correlate with ultrasound features. This is the one single thing that you really want to do. And there are some colleagues of ours who will say if the ACR TIRADS plus Bethesda is greater than 7, they operate. Very interesting, because if the ultrasound doesn't correlate with your FNAC, then there is something wrong. To go back to the crux of my talk, okay, and of course, this is the updated Bethesda scoring system, not really much, but with a combination of the ACR TIRADS and the Bethesda, you really have a thyroid nodule made really, really simple. The number of patients who require molecular testing, the number of patients who require surgery is a very, very small number. I mean, we are submitting an abstract, but I was just comparing our work from 2017 versus 2023. And I can tell you the number of times I walk into the sonologist. I do all our FNACs. There was a time I would do at least 3 to 4 a week. Now I do 4 a month in most cases. So let's move on to point of care ultrasound. Nothing hocus pocus about it. Point of care ultrasound is focus. The question is, do I need focus in my clinic? Let me talk about some of the advances. Let's clarify 3 things. Is it in interest versus expertise? Because it's very important. Are we following regulations? Because India, ultrasound is limited by a very, very stringent regulation. And how do you risk manage it? So the advances are really interesting. I told you how the sensitivity has increased. Let's look at some interesting thing. This is how the world looks at this. This is 2023. Looking at the POCUS brand throughout, most of us are looking at various things for our practice. The one that is commonly used is either the General Electric one. There are people who like the Mindray one. The Butterfly caught a lot of imagination because of cute. But let us see other things. So this is a Butterfly IQ, which is very, very popular among US endocrinologists till 2 years ago, but that's been replaced. What's more common is the Mindray. The one that is very big now is the GE, because it is pretty much wireless. Remember that you need remember, people will tell you all sorts of things, but what you need is a very superficial probe, an 8 to 12 megahertz. This is the Philips Lumify. It's still connected. And the one that's most sold in India is the Sonosite. But remember, all of these are still expensive. If you're in a clinic, they're still 4 to 5 lakhs. And I'll talk to you about the other issues. For the first time with the GE, I think they are breaking the 3 lakh barrier with a single probe. That's about 25 to 30K. So how do these compare? Not much to choose by, but in terms of ease of use and image quality, the V-Scan Air, which is made by GE, is the one that's been the pick of the lot, at least now. How have these changed? Remember that we are not sonologists, and therefore I talk about some of the challenges involved, but have things changed that help us? One is heuristics. For example, here is this is the Korean make, and what you can see is that once you sort of box the nodule here, it actually is already given you the ACR TIRADS score. It has told you that it is solid or completely solid, 2 points. It's hyperechoic, and therefore 1 point. It's wider than tall, 0 points. It's smooth margin, 0 points. and no microcalcification. It's already done the heuristics. Now you can turn on the AI feature. When we started out, we had AIs that looked at a single image and from which will tell you whether it's benign or malignant. And now this is what we call dynamic AI. Remember that many of these are not available in point of care ultrasound, but will make it there in the next couple of years. So this is a dynamic AI, and you can see that here the box picks this up as a benign lesion, and indeed it is a benign lesion. Here it's already giving you a probability of very high malignancy. It's sort of given you the red sign, and indeed the FNAC did show it was malignant. So right in your hand, right in your clinic, your chance of it edging out molecular markers are very, very high. How does it compare to the dynamic AI? It compares pretty well to the ACR TIRADS, a fairly reasonable sensitivity, but very high specificity and a reasonable accuracy that is coming out with it. So in the years that are occurring in front of us, and I know I'm cutting short because we have 15 minutes to do this talk, but we could do a whole bunch on AI TIRADS and AI in thyroid ultrasound. But what is interesting to understand is that the machine learning and deep learning techniques that are coming into the ultrasound right in the probe that is dynamic is actually making things a lot more easier. There are others that are sitting in between the artificial intelligence and the human intelligence, but I thought I'll give you a sample of what's happening. But let me talk about the problems that the Indian endocrinologist is going to face when he wants to do ultrasound in the clinic. If you're sitting in an institution where there's a sonology backup, it's different, but doing it in a clinic is very different. Because your interest versus expertise are two different things. Example, how comfortable are you in giving a report? If you do not have the expertise, giving a report is going to be very difficult. Let me show you and reiterate something very important that is going to limit us from doing this in our clinic, and that is the PNDT Act. What does the PNDT Act says? And I've spoken to, for this talk, I actually went back and spoke to some of the sonologists to see if anything has changed, especially with relates to POCUS. And what we now know is that it has not changed. In fact, this is the act. Just remember that any ultrasound should be done under supervision of an expert in these fields, a sonologist, an imaging specialist, a radiologist, or a registered medical practitioner having a postgraduate degree or diploma or 6 months training or 1 year experience in sonography or image scanning or a medical genetist. But remember, you could have an act, but the law is interpreted by the babus and the others sitting in the government department, and almost always they expect you to be a radiologist. A lot of gynecologists undergo sonography training for almost 6 months, and they submit it and they're able to register their center. Okay, I'm going to have, what do I do if I want to do it? So look at what's happening here. In centers where the ultrasound is intended should be registered at least 30 days in advance, right? All ultrasound machines at the center with the qualified doctors preparing the ultrasound should be registered in the certificate. Fine. No doctor other than the one registered is allowed to use the machine. In the case of a locum doctor, the doctor's name and center, details and state counsel should be sent to the appropriate authority. But importantly, the ultrasound machine should not be shifted from one center to another. Right? Interesting. Portable ultrasound machines should be used as part of a registered medical mobile unit offering health medical services, cannot be used in a vehicle that is not registered. I heard that people are not very stringent about this, but that depends on your state. Right? Now, importantly, a lot of these companies that want to get you an ultrasound machine in your office will tell you that we will find a radiologist who can register for your clinic. Right? Remember that a radiologist cannot be registered for more than two centers at the same time. Okay? And then there are a whole bunch of things like the certificate should be registered, the Form F that needs to be filled, especially that we don't have to get worried about this. But in some states, there is something called a silent observer, which means that you have to record the ultrasound and must be available to a judge or a court of law if it's required. And you need to put a board saying that we do not do communication of sex and the other stuff. But importantly, remember that this is an if you have an ultrasound without these stringent laws, if you get into trouble, a patient gives a complaint, is not satisfied with you, is angry with you, complains, then you have fine, you have loss of your license, you also have suspension of your license, but importantly, that the offense is non-bailable, non-compoundable, and no out-of-court settlement offense. This is the problem and the kicker why many of our colleagues can't have in POCUS, right? So the commentary that we all have, people who have looked at this, is that this is a failure of the best of intentions. That the intentions of the Act from 1994, subsequent revision in 2003, subsequent submissions to the Supreme Court were all fine, but it still doesn't allow you to do an ultrasound in your clinic in many ways unless you are willing to have someone register in your clinic, allow them to back you up. So what is going on? I think this is a good. I'm happy that I brought this up to this forum because this is something we can do. One, I think one of the things that we can do, and I have for the past 20 years been a member of the Medical Council of India, the undergraduate curriculum. I sat in the postgraduate curriculum for endocrinology a few years ago. I think the society needs to be must one talk about certification in sonology as a competency that is part of the graduating competencies in in a DM post graduation or a DNB post graduation, and people should come out with a certification. There should be a co-program with radiology during the DM program that will allow the next generation of endocrinologists to do POCUS. Second, I think we need to start talking to other societies and talk about limited use of pocket ultrasound. A small probe that is going to look superficially is not going to determine somebody's sex. Remember, today you can do an MRI, and that is not under the PNDT Act. What should the individual practitioner do? Be careful. Protect your license first. Do not take the law lightly. Work within the limitations of the law. Go ahead and work with your sonologist. I do every other FNAC of mine myself. I work with our radiology colleagues. In fact, I help them, many of them learn ACR TIRADS. I work with them. Our clinic is very close to the ultrasound center. After I came out of an academic medical center, I still do a lot of stuff. I work with them. Most importantly, work with your sonologist. If you don't have time if you don't have the time or the effort, insist on ACR TIRADS or a single criteria to report. I think each one of you should learn ultrasound and ultrasound guided FNAC. And talk to your professional society about the need for ultrasound to be an extension of your hand. You've come a long way. I think, a regulation that had good intentions has gone awry and preventing us from providing good care. A lot of radiologists are really not interested in thyroid ultrasound. They're more interested in PET CTs and MRIs and the others. Yeah, with very, very great difficulty in our academic center, I had helped one person train in thyroid ultrasound. I continuously work with people to have one person get interested in thyroid ultrasound. But the best person to do a thyroid ultrasound is an endocrinologist who's trained in it. And I think we need to work with regulatory agencies to take care of this. I thought I'll give a different kind of a talk, and I hope this is. I wasn't even sure if this is what Nitin wanted, but I hope this was useful for all the endocrinologists here. Protect yourself and then protect your patients, and I think that is my message. Thank you so much. I really appreciate the opportunity. It's providence that I had to work. I spoke today with Dr. Seshadri at the helm, with another secretary of the Endocrine Society also speaking. I know it's providence, coincidence, or design, but it was wonderful. Thank you so much. Sir, you're muted, sir. You're muted.
We must thank Dr. Krishna Seshadri for a very succinct presentation of what a practicing endocrinologist can do with ultrasound, and also the future directions that this is going to take. And most importantly, how we need to be careful and work within the law. Very well presented material, and I think all the people in the audience would definitely appreciate it. And I think the suggestion that the society and the IMA take up ultrasound training as an extension of the clinician's hand, I think that's a very important suggestion, which needs to be taken further by, say, the endocrine society. Thank you very much for that presentation. And the questions, I think, will be in the end. We now go on to the next talk. Professor A.J. Unnikrishnan, I remember him as a postgraduate student when he was working with us, doing his MD in internal medicine. Later, he worked with us in the department for a year in CMC. A very keen academic who has really gone places. He is currently the CEO of Chellaram Diabetes Institute, and he is involved both in clinical work and in research work, and most interestingly, in outreach programs for rural diabetics. I think very few centers would take on something like that. We should congratulate him for his work in that direction. He has published the largest multi-center study of subjects with pancreatitis and pancreatic diabetes, and that is a very important subject in India. More than 200 PubMed Index publications. He received the Jacob Memorial Prize for the best postgraduate student of patient care during his MD in CMC, and he has received 12 awards and orations the last 10 years, including the DTech Award for Excellence in Diabetes and Technology. I now invite Dr. Unnikrishnan to talk to us about whether autoimmune thyroid disease should be considered multi-system disease. I think that is what he is going to tell us about. Professor Unnikrishnan.
Thank you, sir. It's an honor to be here. And let me just share my screen. May I ask if my slides are visible and if I am audible?
Perfectly fine.
Yeah.
So once again, it's a pleasure to be here and also an honor to have my session chaired by Dr. Sheshadri, who was my teacher during both my post-graduation and also during my early days in endocrinology at Vellore. Let me begin by stating upfront that I will talk about very clinical aspects, and but I would like to begin by paying a tribute to Hikaru Hashimoto, whom, as you know, had initially, after being from Japan, had gone to Germany and for a very short period worked in Germany. And it was during that period that Dr. Hashimoto described the thyroiditis, lymphocytic thyroiditis, after which he returned to being a doctor, to being a family doctor, doing house calls in Japan, where he ultimately succumbed during a house call. When he went to see a patient, he contracted an infection, reportedly a gastrointestinal infection, and he is said to have succumbed to that. So those days, we lost many people in youth in the prime of their life to diseases which are treatable. And Dr. Hashimoto lived a very short, fruitful life, but in that short period of his visit to Europe, he described a disease which became the commonest cause of hypothyroidism worldwide. Now, these are some of the papers I have published. The first one looking at thyroid autoimmunity prevalence. And you can see that the disease is highly prevalent. The prevalence is almost 22%, the TPO antibody prevalence, whereas subclinical hypothyroidism, the prevalence is 8%. If you look at prevalence of overt hypothyroidism, it's about 3 to 4%. If you see the prevalence of TPO antibody in euthyroid adults, it's about 9%. And this is the paper by Dr. Marwa, who actually did FNACs of schoolgirls and said that 7.5% of them could have lymphocytic thyroiditis. So thyroid autoimmunity is quite common. But I'd like to talk about thyroid autoimmunity occurring outside the thyroid gland. In this case, I'm going to talk about thyroid autoimmunity outside the body of the mother and affecting the child. So this is a lady who came to me in her first pregnancy with very classical thyrotoxicosis. The T4 was normal, The T4 was high, the TSH was low, the TSH receptor antibody was positive. She was treated with anti-thyroid drugs and managed uneventfully, though there was some proptosis. This patient had indications for TRAP testing are, of course, known history of Graves' disease. But interestingly, when the baby was born hypothyroid. The TSH was 28 and the free T4 was low. There was no goiter in the baby. The TSH receptor antibody of the baby was also positive. And of course, the baby was treated with levothyroxine, and this was reduced and it was eventually stopped. So we must remember that the TSH receptor antibody is a classic site of extrathyroidal thyroid autoimmunity. It has an N terminal and a C terminal, and depending on where the antibody is binding to the TSH receptor, where the TSH receptor antibody binds, one could have stimulating and blocking antibodies. And in this case, probably the mother had initially produced TSH receptor stimulating antibodies, but then it turned into TSH receptor blocking antibodies. And then the baby developed neonatal hypothyroidism because of the transplacental transfer of TSH receptor blocking antibodies. The other possibility in this case is unrelated hypothyroidism, a chance effect, but in that case, the antibodies would not have been positive. The third situation, of course, could have been that the PTU crossed the placenta, and of course, third is maternal hypothyroxanemia, but the fetus has a thyroid by the time it is born, so that's unlikely. So what is likely in this case could have been that the mother and son did not agree in thyroid function. The mother had hyperthyroidism, the baby had transient hypothyroidism, both had TSH receptor antibody, and the mother's TSH receptor antibody transplacentally, extrathyroidally gave hypothyroidism to the baby. From there, we go on to Hashimoto's encephalopathy and whether it's a myth or a real syndrome. This is one of the nicest studies I found. It was published in 2003, which very extensively described thyroid function in 85 patients who had very high TPO titers with typical encephalopathy. And here they found that about 30% were euthyroid, 35% had subclinical hypothyroidism, and a lot of them had different other forms of hypothyroidism. And what was found is that the majority of the people, as I said, some had subclinical hypo, some had overt, but majority had normal thyroid function, and some had normal thyroid function with levothyroxine. But what is important is they had a range of clinical manifestation, from a focal deficit to a seizure to a myoclonus to a psychosis, a relapsing remitting course, high CSF protein, abnormal EG. Therefore, there was no single diagnostic neurological clue in this study to Hashimoto's encephalopathy. And what was also important is the very dramatic response to glucocorticoid therapy. 44 out of 45 improved the glucocorticoid therapy who were given that. 22 out of 24 who were given glucocorticoid with thyroxine improved, and a few improved with levothyroxine. So if you look at this data, yes, the constellation of neurological manifestations, high TPO antibodies, reversal with steroids constitutes a clinical syndrome. It's not a chance association that antithyroid antibodies are positive. But we don't have evidence to say that the high antithyroid antibodies are the thyroid autoimmunity, so to say, is acting on the brain and causing some autoimmune attack. Now, given the lack of any pathophysiologic link, I think the use of the word Hashimoto's encephalopathy for these cases could be a bit of a misnomer. Now, from Hashimoto's encephalopathy, I go on to something which we do see in our practice. You can see thyroid acropathy or acropathy clubbing in this patient. You can see the clubbing of the nails. It's not contiguous with the nail bed. And you can see the X-ray showing some resorption and the soft tissue swelling and a periosteal reaction. And very importantly, while ophthalmopathy can occur before, but usually within 3 months or after 3 months. Dermopathy a lot of cases can occur afterwards as well, and a majority occur within 3 months of the disease. Now, this is another patient with thyroid acropathy and had marked lower extremity pain. The X-ray, as you can see, is completely normal. But when you see the technetium scan, you can see irregular uptake in the cortical area of the femur, as well as some uptake in the tibia as well. So sometimes when the patient has got pain and the X-ray is normal and there's thyrotoxicosis, one could suspect thyroid acropathy, and it could be picked up by nuclear scan as well. Now, if you look at pretibial mixed edema, paradoxically a feature of thyrotoxicosis and characterized by deposition of glycosaminoglycans and hyaluron out there. This is a very interesting study which looked at 216 cases and they described all the variants. Now, one of the important findings, here I showed 3 graphs. The first graph looks at the purely nodular variant. They studied 45 patients. In the x-axis, you will see the months. In the y-axis, you will see the TSH receptor antibody. What is immediately apparent is that the nodular variant seems to be relatively benign. Though the sample size was small, this is actually a fairly rare occurrence. It's not a very common occurrence, and somebody has collected so many cases and has characterized them and described them. And we may not be able to look at statistical significance with these numbers, but you can see that in the nodular variant, you can see the TSH receptor antibodies coming down and fairly coming down systematically, slowly to normalcy. On the other hand, if you look at the plaque variant, the TSH receptor antibodies, again, the x-axis shows the months and the y-axis shows the TSH receptor antibody levels. You will see that there is a fairly waxing and waning course of the TSH receptor antibody, showing that these may require treatment. Of course, what is the treatment? Intra-lesional steroids and things like that. But at least some aggressive treatment may be required there. In very rare cases, extremely rare cases, you can see the elephantiasis variant of pretibial mixed edema. That's just like the traditional elephantiasis. And when you see a hyperthyroid patient with typical elephantiasis, instead of course, you could still think of filarial elephantiasis, but you must also think of the elephantiasis variant of pretibial mixed edema. The TSH receptor antibodies seem to be even more heterogeneous. Of course, this is only one patient who had a titer of almost 1,186 of the TSH receptor antibody. Remember, the TSH receptor antibody titers that we use in practice will not differentiate between the stimulating and the blocking type. So we don't know really, but yes, the antibodies seem to be there and seem to have some sort of a waxing waning course. So nodular variants seem to recover well, and other variants may require early and aggressive treatment to prevent the elephantiasis stage. Now I go on to the other extrathyroidal autoimmunity, and that's the thyroid eye disease. We all know that the most important cell in thyroid eye disease is the fibroblast. And earlier it was believed that the TSH receptor antibody binds to the TSH receptor on the fibroblast, and that results in differentiation either into adipocyte or myofibroblasts. The adipocyte and myofibroblast differentiation, again, the stimulation leads to hyaluronic acid deposition, glycosaminoglycans, inflammatory molecules. And if you see, it is the resident C34 fibroblasts which eventually sort of differentiates. So if you see, inflammation is a very key component out here, but I'd like you to look at the little green receptor here, and that's the insulin-like growth factor receptor. And today, it is well known that the TSH receptor antibodies stimulate the TSH receptor, but there is a stimulation of the IGF-1 receptor, either by IGF-1 receptor autoantibodies or a co-stimulation occurring because of the TSH receptor antibodies binding to TSH receptor. Very interesting to know that even TSH as well as TSH receptor antibodies bind to the TSH receptor. Indeed, if you look at TSH alone, it stimulates the formation of hyaluronic acid, because this is a laboratory study. Again, you can see the TSH here and the hyaluronic acid deposition. With IGF-1, you would get a little more deposition with IGF binding to IGF-1 receptor, but the combination of TSH receptor stimulation and IGF-1 receptor stimulation would lead to a further occurrence of hyaluronic acid deposition and orbitopathy. Eventually, we don't know why thyroid autoimmunity occurs in the eye. We do know that it is because of expression of maybe the macrophage, maybe other cells of MHC class 2, and MHC class 2 presenting a thyroid antigen to a lymphocyte. As you know, a lymphocyte can bind to a thyroid antigen and produce an immune attack only if the antigen frame or the frame in which the antigen is presented is recognized. And this frame is provided by the MHC class 2. And therefore, why does the MHC class 2 bring about a presentation of a thyroid antigen to a lymphocyte? Is it because some clones have got through, some T-cell clones have gone through, or some MHC class 2 has expressed it aberrantly? Is it because of molecular mimicry that certain viral or other particles are similar to the thyroid antigens, and therefore an attack by an antigen-presenting cell to a lymphocyte also produces a presentation of genuine thyroid antigens? We don't know the reason. There are several theories. But yes, we do know that the eye is a very favored site of this attack. Now, sometimes you can get thyroid eye disease-like picture with normal thyroid function, and sometimes we say that this is euthyroid Graves orbitopathy, but it may not be so. All thyroid-like eye disease may not be euthyroid Graves orbitopathy or euthyroid thyroid eye disease. So here is a case of a 67-year-old man, 1 year history of swelling in both the eyes. There's a protrusion of the right eye, and there is a blurred vision. The extraocular movements were limited and visual acuity was reduced in both the eyes. MRI showed there is a swelling of the lacrimal gland and also the lateral rectus muscles, and there were mass lesions surrounding the optic nerve as well. The laboratory tests of this patient showed that the IgG4 levels were very high. The reference was 3-201. So this was basically IgG4 related ophthalmic disease. And to confuse this picture, of course, this biopsy confirmed a lymphoplasmacytic infiltrate. There was no fibrosis, and prednisolone was started orally, and the patient got better. But to confuse this picture, sometimes thyroid eye disease itself can be associated with high IgG4. So whenever a Graves orbitopathy has got elevated IgG4, that is likely to be a younger patient who's got orbitopathy, somebody with a more severe course, and somebody with a higher clinical activity score. Theoretically, this patient should have a good response to rituximab, but this hasn't been studied in any trial. But it's prudent to remember that if there is a Graves orbitopathy patient with elevated IgG4, that patient can have both classical Graves orbitopathy and IgG4 related ophthalmic disease. At present, you can't call it IgG4 related Graves disease. The better term is Graves disease or Graves orbitopathy with elevated IgG4, which is another, autoimmune activity. So friends, these are all the different autoimmune diseases that occur outside the thyroid, even with thyroid autoimmunity. I began by showing you a fetus affected by thyroid autoimmunity for a mother with thyroid autoimmunity. I showed cases of the eye, the pretibial myxedema, thyroid acropathy. I'd like to conclude by the concept of horror autotoxicus. This was Paul Ulrich in his book Collected Studies of Immunity. He said that self-destruction cannot occur because self-destruction is not consistent with evolution. It's bad for the body, so the body will have a horror of fighting against itself, and he called it horror autotoxicus. But he was so wrong that he was really right, because if that happened, if the body started fighting against itself, which it should never do, that was the beginning of an autoimmune disease, and that was a concept which led us to autoimmunity. So Paul Ulrich, who's one of the fathers of immunology, is also the father of autoimmunity, via his observation that autoimmunity is going to be bad for mankind. And what makes some of us react against the orbital cells and the thyroid cells? I'd like to end by this quote by Siddharth Mukherjee in his book, The Song of the Cell. He says that an organism is but a cooperative union of units. It's a parliament of cells. But where does the union begin and end? What if a foreign cell tried to join the union? What passport must it carry that enables it to pass? Is it the MHC type 2 not presenting an antigen? Or is it the MHC type 2 that presents an antigen and results in autoimmunity? If it doesn't present that antigen, there is no autoimmunity. If it presents the antigen to the T lymphocyte, there is going to be autoimmunity. So what is that passport, and why is that passport there at that checkpoint? That's a fascinating question in any autoimmune disease, particularly in thyroid autoimmunity, which is now not restricted to the thyroid gland, but can occur in different parts of the body. Friends, it has been a pleasure discussing this topic with you, and thank you so much for listening to me.
Thank you. Can you unmute me?
So we can hear you well, sir.
Yeah, okay. Thank you very much, Dr. Uni, for taking us through the journey of autoimmunity, basically starting with the thyroid gland, but extending to other tissues in the body. Very nicely presented work, and the session is now open for question and answer, and I have a request for Dr. Nitin to keep it brief because of paucity of time. And so, can we get on with the questions? Have they been posted? Then we can ask the speakers to.
Yes, sir. I request Dr. Arun and sir to please moderate the questions. Dr. Arun, would you like to address the questions to the speakers? We cannot hear you, Dr. Arun.
You're muted, I think.
Can you hear me now?
Yeah.
Yeah.
My the screen is not working. Okay. Nitin, do we have any questions from the floor?
Yeah, well, only the ones in the chat.
In the chat box. Yes. Okay. That's great. So I know we are running out of time. Sujoy, wonderful talk as usual, and you have made it so simple for us. There are a couple of things that I thought might be just worth asking you. You did mention that you didn't want to talk about microRNA, and I suppose that's because you haven't published the data and you want to keep. But with whatever available data is out there now in the literature, where do you see the place of microRNA versus cell-free DNA, if you were to foresee it?
Well, it's matter of conjecture. I haven't analyzed the data completely, but I would presume in individuals where we found that the cell-free DNA is increased, and yet I have not found a driver mutation. So there's going to be about 25% of people who will have raised cell-free DNA, but the driver mutation will not be present there. There, having a permutation and combination of overexpression and underexpression of certain microRNAs might give us a clue about the subtype of malignancy that we are actually anticipating in that group. So it's going to be complementary. So it won't be microRNA is better than cell-free DNA. You've got to use the data together.
Okay, that makes sense. Okay. Now, the other thing is that in terms of the estimation, because you said that the DNA selfie concentration or estimation of that would be very useful. Would that be, I mean, obviously that will be useful in monitoring the disease as well. How would it be useful in terms of treatment, especially in resistant case of DTC, where you're using immunotherapy? Do you think that would be useful in those sort of cases?
I think I shared the data only in the diagnosis. We already now have enough data for detection of residual thyroid tumor. It's another paper that we are writing up. With regards to follow-up in detection of recurrence, it's a multi-center study that ESI has funded. We still don't have data on that. So at this point of time, I can, have a conjecture that it might be useful in detection of recurrence. But
is there any literature on this?
No, there's nothing. So we don't know, having a hypothesis and actually proving it is two different things. In terms of EGFR mutation in lung cancer, it has a definite role. So if you're using immunotherapy, it can tell you what is the tumor load, is the drug, the tumor responding to it. As of now, conceptually possible maybe, but we have zero data on it. So my next step is to actually figure out how is it able to detect recurrences. In the talk, I was trying to tell you about why is the cell-free DNA increased? And I was trying to say that it's apoptosis and tumor necrosis is what is postulated. It might not be the case. We are actually looking at mechanisms of that. And I'm grateful to the Indian Thyroid Society for having given us a funding for that. So that data is going on as well. So I can't answer that question with certainty. It's a possibility, but we need to have research and data to actually prove it.
Anything you'd like to add, Sheshadri, sir?
Just a quick comment. Your studies with cell-free DNA, do you see some light at the end of the tunnel for distinguishing follicular adenomas from follicular carcinoma?
Right. So in our data that we have as of now, in follicular carcinoma, the cell-free DNA is increased. In follicular
total quantum is it?
Yes, and in follicular adenoma, there is no increase in cell-free DNA. Added with that, both follicular adenoma and follicular carcinoma will have RAS mutation. So the RAS mutation detected in the cell-free DNA does not help us differentiate between the two, but the concentration of the cell-free DNA helps us differentiate follicular carcinoma from follicular adenoma with more than 95% sensitivity and specificity.
Another quick comment. The Chinese study that was published recently in the Lancet, they used a two-step centrifugation to get the cell-free DNA out. First stage, 3000 RPM, which is what you're using. And the second stage, I think 15,000 RPM. Do you see any advantage in doing that?
So
two-step centrifugation.
We've tried to do that. We did not find any difference, number one. So we used a biophotometer for estimation, and then we again used a qubit to actually revalidate the finding of what we were finding in terms of the concentration.
Thank you.
Thank you, sir. Any other comments from Jabbarji? Nitin, any other comments? Okay. So can I ask Krishna?
May I ask one question to Dr. Unni? I do not know the answer also. So IgG for orbital disease is not that common if you take the literature. So any pointers or any clinical stigmata by which can suspect the possibility of IgG for disease, thyroid disease, Unni? Dr. Unnikrishnan, you are muted.
Thank you for that question, sir. I think one of the important classical features of IgG4 related ophthalmic disease is lacrimal gland involvement or dacryoadenitis. And I'm sure we must be remembering in our MBBS days, we used to hear about this McCluke's disease, which had both lacrimal gland and salivary gland. That was the older name for this IgG4 related disease. Later on, many cases of McCluke's disease now found to be like this IgG4 disease. Second is, it looks like Graves' orbitopathy, but inferior rectus is the usually affected muscle, followed by other muscles. Thirdly, there will be some mass effect prominently seen in masses may be seen. Fourthly, 68% of patients with IgG4 disease also have systemic involvement. Salivary gland is involved multiple lymph nodes may be involved. Even the pancreas has been shown to be involved. So these are some signs like prominent involvement of the lacrimal glands, the inferior rectus, salivary glands, lymph nodes, pancreas. If we see something like that, then we should think this is not the typical Graves' orbitopathy or thyroid eye disease. This could be IgG4 related disease. So this is what I could read from the literature.
That's great, Tony. Thank you so much. That was one of the doubts that came up during the talk. Thank you. Krishna, are you there?
Yeah, sorry, is there.
Okay. Krishna, I just wanted to, thank you so much. That's a wonderful talk, very, very practical. I understand it's very useful for the clinicians in the diagnosis using this ultrasound, which is what you were talking about. But in terms of follow-up for malignancies, picking up visual disease, perhaps lymph node disease, those sort of scenarios, do you think general endocrinologists need more expertise? Should we be actually be doing that, or should we actually? I know you work with a radiologist and you always advocate that. But what's your opinion in terms of when it comes to following up a disease like a malignancy?
So remember, the ultrasound is probably a wonderful tool, especially, remember it's an operated bed. There's nothing else to look at it. So picking up recurrence and picking up residual diseases are very, very nicely done in an ultrasound. Now, there's a big difference between interest and expertise. The second thing is a big difference between certified expertise and being able to report it. So, one, I think an experienced endocrinologist, I can tell you that that many of us can give a run to the radiologist who's sitting there, run for their money when it comes to picking up these, because we've been doing it for years and years with them. But the thing is that who can certify it? So work with them. This is why I brought up this point about getting certifications as part of the postgraduate curriculum. That when you have documented it in your logbook and it's part of what you've been certified in, then it's easy for you to say, look, I've looked at the ultrasound. I believe that there's a recurrence. This is enough for me to send it to a surgeon or write it down. But short of that, you're in trouble, because if the standard for negligence is doing something that you do not have expertise in it, right? So yes, develop the experience, and if you can get the certification, get the certifications done. But I think this needs a longer stretch that bodies like the Endocrine Society need to work with, the NMC and others. Many of our colleagues are sitting on that board to see that outcomes are documented in people's training. The second is to learn that the margins of strict radiology and strict endocrinology are blurred. That an interested endocrinologist can get this and to a certifiable competency, right? So can you pick it up? Absolutely. I'm sure Arun can pick it up, Dr. Seshadri can pick it up, Uni can pick it up. We've been doing it for years, right? But none of us will be signing a radiology report. And that is where that jump needs to happen through work that our society does. But today, if you've just come out from practice and you're interested, don't sign that report, but keep at it.
Pardon my ignorance, Krishna, in terms of what is the practice in the US? Because I know they're all
So you can get certified in ultrasound.
And you can sign it off.
So remember, my friend, the person who I've leaned on the most when this, and has helped me and gave me my first break in learning, and of course now doing ultrasound workshops with her is Susan Mandel. But remember, Susan Mendel has a dual degree in radio. She's a professor of radiology and endocrinology, right? So the US allows you to specialize in both. But also in the US, you can certify yourself on these, right? The Endocrine Society has programs, various distinguished programs, and so office ultrasound is a part of what endocrinologists do. And that's why, and remember that this is not something limited to endocrinology. For example, the emergency room, ultrasound is a very important tool. In surgery, it's a very important tool. In obstetrics and gynecology, it's a very important bedside tool. what we need to do is to see how we can, keep the spirit of the PNDT Act, but at the same time, make sure that the benefits of this wonderful tool are available to one young endocrinologist to be able to do, but also to our patients. I think our patients will benefit from the expertise of someone who's interested in it. I think that's where we need to go, and I'm glad that all the big people in the endocrine society are here as I put this plea forward. Time to write a white paper, get it published in the JCE, take it to the NMC, take it to the IMA and other people to talk about POCUS as a very legitimate part of what super specialty care is all about.
Thank you. Thank you.
Dr. Krishna, just a quick question. The focus equipment that you mentioned, are they as good as the standalone ultrasound machine?
So they are getting there. Remember that it is more than the probe; it is a software, right?
Okay.
And what I anticipate is that in the next couple of years, remember I showed you a couple of photographs. One is the SD9 Samsung, the other is from the KOIS, the Korean software. The dynamic AI will come into handhelds, because more than the radiology practice, it is the focus practice that dynamic AI is going to make the hugest of differences. So the translational time, there was a time when that the big companies would actually prevent this kind of innovation, but today they are lapping it up like nobody's business. So dynamic AI is going to make the big difference. And remember, I mean, so when you first did the ultrasounds, somebody had to, the B modes, somebody had to tell you that this was a thyroid. Today, it is so beautiful. So the handhelds are doing absolutely beautiful. They may not be. There are some technology like the Pure Touch, the Pure View technology that has still not made it to the handheld. Elastography, not yet, but it's only a matter of time when they'll get there.
Thank you, Krishna. Perhaps a last question to Unni, and then I know we are running short of time. Unni.
Dr. Unni, can I
Yes.
ask Dr. Unni?
Yes.
There was some interest at some stage about antibodies that stimulate thyroid cell proliferation. And there was a concept that in autoimmune thyroid disease, you see chaps with great, Hashimoto's thyroiditis with a big gland, and you see those with atrophic thyroiditis with high titer antibodies. And so people were working on thyroid growth stimulating antibodies. Is that work still going on, or is it sort of fizzled out?
Not aware, sir, but I'm aware
Not
that it's a
aware.
very interesting topic, but not aware of directly of any
Okay,
work in that
okay.
regard.
Yeah.
Unni,
Yes.
I mean, we have been seeing quite a lot of this link with Hashimoto and COVID vaccine. Is there anything to suggest that the disease is much more severe, or there are more extrathyroidal manifestations in such cases? I haven't seen in literature. I was just asking you because that is a very relevant area that we see these days.
Well, there's no evidence that that's completely different. There is some evidence that of a causality in the sense that that it's a sign of inflammation, and that the thyroid cells express ACE2 receptors and also the TMPRSS2 receptors they express. And of course, the thyroid is very close to the pharynx and the throat where COVID is there, so that may be a local effect as well. But I'm not aware of anything being very severe in COVID-related thyroiditis, Hashimoto's versus others. I don't know. And all this data, to my knowledge, is not Hashimoto's, but it mainly relates to subacute viral thyroiditis situations.
Thank you so much. So let me thank all the three speakers, and over to you, Nitin, for the rest of the proceedings. Thank you.
Thank you, Dr. Arun, and thank you, Sheshadri sir, for moderating this. And it was truly a feast for all of us listening. And I know for sure that not only on YouTube, but even on the Endocrine Society website, there are a lot of viewers listening actively right now. And I'm sure all of us have benefited with this CME. Thank you, one and all. And we move ahead with the program. And since this is a birthday celebration of our very own society, there should be a cake cutting. But to have a virtual cake cutting, we thought it would be good to have a glimpse of all the activities that the society does in one calendar year. And if I have the permission of our president, Dr. Jabbar sir, to play the video for our society's birthday celebration. So I shall now play the video of the Endocrine Society's activities over a period of 1 year. Yeah, just 1 minute. So a big round of applause and a very happy birthday to our society. May it live many hundred years ahead. And with this, I hand over to my co-host, Dr. Shaila.
Thanks, Nitin. That was an absolutely fantastic academic session. And I know everybody's actually also looking forward to the next session, where I have a very good friend of mine, Dr. Gagan Priya, who's a senior consultant endocrinologist at Fortis Hospital, Mohali, who's going to be speaking to our president, Dr. Jabbar. I know Nitin has already introduced Dr. Jabbar, but it gives me great pleasure to say just one line about Dr. Jabbar. I know him since my residency days, and he was the only one who used to call me Shaila ji. I still remember that so distinctly. One of the most humblest, sweetest, kindest. I have a list of adjectives for him, but I won't go into that. But over to you, Gagan, to grill Dr. Jabbar and to, sort of let us really ask our president and talk to him and understand from him what is his vision regarding the Society of India. Over to you, Gagan.
Yeah, thank you so much, Shaila. I think up north, the weather is not for grilling, rather we are chilling out here. So we have temperatures of 10-degree maximum daytime and hitting 3-4 degrees at night. So we are as cool as a cucumber right now. So Dr. Jabbar, we put this question to the endocrine members, the members of ESI. And of course, you're the best person to lead us through this. Inputs and suggestions regarding what ESI can do to improve on endocrine research, academics, as well as clinical practice. And I was very happy to listen to Dr. Krishna Sheshadri's talk about, ultrasound certification and his proposal that we could work on it. In fact, this did come as a proposal from one of our members, group members. And along with this, the proposal was also whether we can collaborate to create a clinical, certification for clinical densitometry. What would be your take on that?
Thank you, Dr. Gagan Priya, for a nice starting point for today. And certification, definitely, it's a very useful and probably need of the hour, I would say. In fact, and I wanted to ask this question to Dr. Krishna Seshadri also. The legislation of certifying USC report is not a joke now, because now the law is becoming a little stringent. It's very difficult to violate the rules. Even now, in our department, we are also doing sonology and we are taking FNAC also. Okay, of course, I'm working in a government now and will come to my department and ask me. But I think that should be a good idea. Definitely myself and my team, and of course, you are also my team member. We have to do that. We should do that. Definitely will achieve that. That's my plan. Okay. That's my vision also.
So I think that will be a brilliant move forward. I mean, yes, the institutes already, I understand a lot of institutes have their own sonology machines, but can we create a kind of an environment where even the private clinics can, work towards the certification, maybe do a course and get registered?
That's the reason, madam, I'm telling you. See, sonology, anybody can do sonology, but if a clinician is doing sonology, that makes a lot of difference, right? You have a clinical backup and you have the biochemistry, everything you have. So very easy to interpret, and even the monitoring becomes very easy. That's the reason I'm telling you it's the need of the hour, okay? And we'll try for that, definitely, with our team, we'll try to do that, okay?
Thank you so much, sir. So another input that had come from Dr. Sridevi from Hyderabad, she was talking about, now we have started patient registries for quite a few, rare diseases. Can we also, in a way, start some patient support groups for rare disorders? Like US has a Turner support group program going on. So we can create some kind of an information and a support platform for them.
Good. And in fact, we had a discussion with the Dr. Hari also, see, we will plan for a special interest group, something like that, Mr. Turner. Those who are in the suppose 10 endocrinologists are there from West, North, South, something like that. So even during our AC Con, so we can have a small session for them. And in addition to that, it's a good idea to have a social and support group. Okay, we'll have a discussion, detailed discussion in this regard, and we'll definitely try to look into that. Over.
Yeah, great, sir. Thank you. So one more suggestion that did come up was regarding ESI guidelines. And I do remember we have discussed the issue of, bringing in guidelines, and Dr. Sanjay Vidada was also here in the same meeting. So how do we move forward? Nitin has already led the obesity guidelines in tandem, but how do we move towards building Endocrine Society of India guidelines, which would be specific to our country?
Very good idea. In fact, we had a discussion in our EC meeting also, but we have a small issue, if you are sort of data from our own country, then we'll start looking into that. That was our plan. And of course, this idea is in our mind. We'll examine it again and we'll try to do that. Okay.
True. So yes, I think so. Under your leadership, we are moving forward in the right direction on that idea. So one more suggestion that did come in, and I found it interesting, was, can we create a directory of, ESI acknowledged endocrinologists across the country? I mean, we do have our members list and everything, but can we create a directory where patients can access the directory and locate endocrinologists in various cities?
I think we had an idea like that, and I think the social support group already started working on that. That's my memory now. Am I right, Dr. Hari?
Yes.
Yes, sir. As of now, we are working on it in the website. Very soon we will be having the map, India map displayed, where you just put a cursor, you will know the endocrinologists who are the members. That is being done. Only issue I'll say is we are not giving a directory. I mean, obviously phone numbers I won't share with anybody also. Even mail IDs to put, sometimes it is going to fall into a wrong hands. So we are just going to display the name and his ESI number, so that I mean, he cannot do anything else with that number, or the name of the person who is our member that is already being working. Possibly in a 2-3 weeks time, we will have it on the website itself.
So that sounds great. So, so I think this was majority of the questions we got. Some of these were replicated again and again. So there was one point that I think Dr. Krishna Seshadri is here, but he had again iterated and personally sent it to me. How can we improve on the independence of ESI as a distinct body in terms of, the sponsorships and everything can be taken out and ESI stays as an authoritative body?
It's a very tricky question, in fact. Okay, even though we need that, so independence in terms of what, that will be a big question. And I will look into that, and we'll try for certain avenues also for that. Okay,
Sure.
Let us keep it in our mind. Okay.
So I think I'm getting the cue from Nitin that we are short of time.
Anyways, I think I wanted to appreciate Gaganji, and you have collected a lot of inputs also for our society. Thank you very much for that. Okay, over to Gaganji.
So thank you so much for the opportunity. But in 1 minute, if you would like to, share your vision for the next coming year, like what are we doing till the next ESICon?
That's the toughest job for me. So my previous presidents, okay, they were doing an excellent work, excellent work. So all areas, they are really involved, and they did a lot of things for that. In fact, I wanted to concentrate on academics in endocrinology. Of course, I want to concentrate on postgraduates and the education in remote areas. Okay, so I think endocrinology will be acknowledged, and our juniors will have a lot of chance also. So people will get a lot of information regarding endocrinology and endocrine problems. So that way, I want to increase the awareness factor. These are the 2 or 3 factors planned for the time being. And of course, during our EC meetings also, we'll have this type of discussion, and we'll try to do more and more in near future. That's my plan. Okay, Gaganji, over.
Thank you so much. Thank you. And I think I'll wind the session with that and hand back to Nitin further.
Thank you, Dr. Gagan and Jabbar for that very insightful session. And just before we close, I also acknowledge the presence of our immediate past president, Dr. Sanjay Badara, who's joined us today evening. And welcome, sir. And I think with this, may I request our Honorable Secretary of the Society, Dr. KVS Harikumar, to please propose a vote of thanks.
Thank you, Dr. Nitin, and greetings to all. New Year greetings from Endocrine Society. Professor Seshadri, sir, thanks for taking your time out and actively participating, chairing, and actually giving some insights, which we all have to read up at some point of time, even at tonight. And Professor Jabbar, sir, Professor Barada, everybody who has joined, the team who has worked, Dr. Nitin, Dr. Shaila, Dr. Gagan for conducting an entire EC, and Dr. Mohan for putting 100 people onto website to actually post questions. Unfortunately, we couldn't take more, but definitely we are available at every time, and you can keep sharing the inputs to any time. And thanks to the excellent set of speakers, Dr. Unni, Dr. Sujoy, and Dr. Krishna Seshadri. And it is my fortune that 2 of my predecessor secretaries are there in the same forum, on the shoulders of whom I am standing and showing my face to all of you. So thanks to both of them for doing excellent work, and so that paving the way for others to excel. So thanks to all of them, and thanks to everybody who has participated. And I'm sure we will do better, and we will strive to be the best society of India forever in times to come. Thanks to all.
Thank you so much, sir. Good night. Bye-bye.
Thank you.
Good night. Bye.
Thank you. Good night, everybody.
Good night.
Good night, everyone.